Hello everybody, my name is Dr. Carlo Ojet. I am an emergency physician and the founder of DrER.tv. This video is going to be about diabetic emergencies, and this video is intended for anybody in the healthcare profession, anybody who provides services to patients with diabetes. That includes medical assistants, medical students, pre-medical students, nursing students, nurses, even other physicians like resident physicians, people still in training, or physicians who just want to review hyperglycemic and hypoglycemic emergencies in a short amount of time. I have spent many hours reviewing and taking notes on different diabetic emergencies so I can provide you with a very concise but very productive, very high yield video about diabetic emergencies. And the reason I decided to do this video is because in the same day I saw two patients with blood sugars above 1,000. Even though the presentations were similar, their diagnosis was different and therefore the treatment was slightly varied. So let's get to it. Let's get started with diabetic emergencies. Well, first, there's two main classes of diabetic emergencies. That will be hypoglycemia and hyperglycemia. Normal blood sugar should be between 70 and 100, and some people can have 60s and be just fine, but they might start developing symptoms there. Low blood sugars can present with sweatiness, diaphoresis, altered mental status, even stroke-like symptoms. People can pass out, people can be very sweaty and altered, and so on. The main thing with hypoglycemia is they need blood sugar. If they're awake, you can give them a juice, you can give them a hard candy. If they're not awake, you can give them glucose gel under the tongue and let it absorb under the tongue. There's a big venous plexus and the absorption of stuff is very quick. If they are unconscious, then you have to give sugar some other way. At that point, you start an IV and you give in dextrose, whether it be as an amp bolus, or if the patient knows they're diabetic, they might have something called glucagon. Glucagon pens are like EpiPens, but for diabetics. So when their glucose is way low and they have no IV access, you can give them this emergency injection who sends the signals to the liver to release blood sugar, and therefore the sugar goes up. If this patient is a diabetic, make sure you check for, do they have a pump, an insulin pump? If they do, turn it off so that it doesn't keep releasing insulin, therefore making the blood sugar stay down. Once they wake up, you got to ask them about what medicines they take. Do they take insulin? Do they take their normal dose of insulin? They didn't eat enough? Maybe they skipped a meal. Maybe they didn't adjust their carbs. Maybe whatever. There's a recent adjustment in the insulin dose. All those things you need to consider in terms of what you're going to do the treatment. But one of the biggest questions, one of the biggest pitfalls in emergency medicine and people with hypoglycemia is we forget to ask about oral hypoglycemics, especially the newer kinds that are associated with prolonged low blood sugar. So the patient, you give them sugar, they go up, they feel fine, you review their meds, you tell them, okay, skip your medications, and we send them home. The problem is that medications on their system for 12 hours, and then 4 hours later, the sugar dips down again, and they present again hypoglycemic, or God forbid, they died at home because of the low blood sugar. So make sure you look for long-acting hypoglycemic agents, and if they do, you admit them to the hospital for observation. If the patient in the emergency department comes in and the sugar is already up, they're awake, they're talking, you give them a meal, you tell the nurse, check the sugar every 30 minutes for the next hour, hour and a half, and if that sugar has remained nice and steady, they can go home as long as they're not in this long-acting hypoglycemic agents. If they are, you're going to admit them for observation. If their sugar drops, then you're going to treat that again, and then it goes up, and then it goes down again, and then you're going to figure out, wait, they can't go home. At that point, you can start an IV with dextrose, D5 water, D5 half normal, or D10 even, if their sugar is very low. And if it's persistent hypoglycemia, or something I call refractory hypoglycemia, then you're going to give not only the IV fluids containing sugar, but you can give, of course, glucagon, which we already talked about, but you can give something called octreotide, which is supposed to reverse metabolism stuff and then allow the blood sugar to become normal. So again, two types of diabetic emergencies: low blood sugar, we already discussed that, and hyperglycemia. So let's go ahead and talk about the different kinds. You can have both type 1 diabetes, type 2 diabetes. Some people talk about type 3 diabetes. The type 1 diabetics, the one that you usually say it's a young person who first presents with DKA at a young age. Type 2 diabetics, older age, obese patient, they have other comorbidities and they're not insulin dependent. But that's not entirely true. It's an oversimplification of diabetes, since some type 2 diabetics might require insulin during their treatment. So somebody calls either type 3 diabetes or double diabetes. Some people have both type 2 and type 1. That means that even though they're type 2, they might at some point present in diabetic ketoacidosis, which is the one generally ascribed to type 1 diabetes. Type 1 is the autoimmune because you're insulin deficient, whether it be they're not producing enough or the insulin itself is damaged and doesn't act. Type 2 is usually a cause caused by dehydration, being very dry. People with high blood sugars, they have a diuresis effect. They start peeing a lot. And as they pee a lot, they become very dehydrated. The sugars start going up. And these people, type 2 diabetics, are also slightly insulin deficient. One of the things we're going to talk about, one of the pearls that we're going to talk about, is just because the blood sugar is normal at the time you're seeing the patient doesn't mean that they are not in DKA. DKA stands for diabetic ketoacidosis. So the patient can have ketones, be acidotic as identified by blood pH, and from the research I read, there is no need for ABGs, painful and potentially complication causing arterial blood gases. You can do a venous gas because the correlation of the pH, which is what we're looking for, it's very, very close. So a normal blood sugar does not exclude decay because they could be ketotic and they can be acidotic, and you can see that by low CO2 or by an anion gap, okay? And if they have normal blood sugar with diabetic ketoacidosis, it's usually have to do with a sodium glucose transporter blocker, number 2 blocker. So it's called the SGL2 blocker. And these medications, usually the name ends in flossin. So if the patient's any of these medications, they can present in euglycemic diabetic ketoacidosis. One of the examples is a medication called Invokana, which is very popular because it can actually decrease weight loss, so patients like being on that medication. But up to 1% of patients who are started on this medication will develop decay within the first month. Patients who present with very high blood sugars will have a drop in sodium. That is called pseudohyponatremia. That means it's not real. Yes, the number will come out from the lab as a low, but this is because of the way the machine reads it, the sugar affects it and it makes it look low. So that's why it's called pseudohyponatremia. The sodium will go down 1.6 milliequivalents for every 100 milligrams per deciliter of sugar. So if your sugar should be 100 and you're 1,000, so that's 9 times 900. So 9 times as high. So 9 times 1.6. So that's about 15. So you could be a sodium 15 milliequivalents lower than it should be. Actually, you would expect the patient to have hyponatremia, given a very high sugar. And the fact that the sodium is normal should alert you that the patient is actually hypernatremic. Not a big deal because these patients are very dehydrated. You're going to give them tons of saline, which is relatively low in sodium compared to the blood, so they're generally okay. We already said that we don't need to get ABGs, we can do VBGs. The correlation is great, the complications is less, the pain to the patient is way less. So let's that. All right, we already said this part right here. Treatment, number 1, 2, and 3 is fluids, and fluids. Sometimes these patients are so fluid deficient, you have to do as much as 5 to 10 liters of fluids. That's a lot of fluids. Now you're gonna start with normal saline, but after giving 2 to 3 liters, then you have to change the fluids because you don't want to end up developing hyperchloremic metabolic acidosis. So you drop it down to half, change the half normal saline to D5, half normal saline once the sugar is about 250. So first you change it from saline, you change it to lactated ringers or some other kind of fluid, and then eventually once the sugar drops to 250 or so, you don't want the sugar dropping any further. So then you start on D5, half normal saline. So initial fluid of resuscitation, normal saline. Once you give 2 or 3 liters, you change to lactated ring or something like that to avoid hyperchloremic acidosis. And once you get to a sugar of 250, you don't want to drop any further. You want to keep them there until you close the gap, until you treat the acidosis, which means you're going to be given sugar. You're going to be given D5, half normal saline at that point. Kussmaul breathing. We can't talk about DK and diabetic emergencies without talking about Kussmaul breathing. Kussmaul breathing is that deep breathing that patients get because they are extremely acidotic. Their body is trying to blow off CO2. By blowing off CO2, they're blowing off acid, and they present with Kussmaul breathing. That's when you get that odory, fruity smell, which I actually can't smell, but that's what you would expect. So you would expect a patient breathing real heavy like that would be very acidotic. So what about insulin? Should you give insulin right away? The patient presents and their hyperglycemia in the 600, 700, 800, 900. No, not right away. Remember, they are very dehydrated. The number one treatment is going to be fluids, fluids, fluids. You have to check their potassium. If their potassium is above 5, then no problem. Give them an insulin bolus, start insulin drips. If their potassium is between 3.3 and 4.9, so below 5, then you gotta be careful because you give insulin, gonna drop the potassium further, and that can be dangerous to the patient. So you're gonna replace the potassium, bring it up before you start giving insulin, and especially before you start an insulin drip. And if the potassium is definitely below 3.3, then you definitely want to replace that potassium through the IV route. Check the potassium, make sure you're in a good range, and then you can do both. So when you are between 3.3 and 4.9, you can actually give the insulin as long as you're giving potassium in fluids as well. You can give 20, 30 milliequivalents of potassium in an IV bag as you give the insulin drip. But so give fluids, fluids, fluids. Do not give insulin until you know the potassium. If the patient's potassium is low, you can send him into cardiac arrest, and we don't like that, all right? Caution, false elevated potassiums due to acidosis. Some patients might have 5.5 potassium, 5.6 potassium, and not only you have to exclude the fact that that could be hemolysis of the sample itself, but that could be a falsely elevated potassium level. So you say, oh, it's 5, we're fine, but the real potassium is actually closer to 3.3, and now you're in trouble because you're given insulin because you saw it being 5.5. So what about bicarb? The research I read is that you have to be really, really careful, and there's almost no reason to give bicarb in hyperglycemic emergencies like DKA. Yeah, bicarb can cause a paradoxical CNS acidosis. Paradoxical CNS acidosis, and that's bad because especially in kids, it can induce brain edema, and that is no bueno. That's very, very bad. Now, if the pH ends up being the research that they've done, and in giving bicarb, and the recommendations that it's very acidotic, or if they're coating. So anything less than 6.85, or they're coating, of course, they're already coating, they're already dying. Go ahead and give bicarb. But if they're not coating, you gotta give the bicarb very slowly, and you gotta watch. And again, you watch for these potential complications. For the most part, they said most patients will not need bicarbonate during diabetic ketoacidosis. So in about 6 to 8 hours, as you give the insulin drip, then you're going to switch to subcutaneous insulin, and you're going to switch before you turn off the IV drip of insulin. What are you going to be checking on the patient, blood work after blood work after blood work, to make sure they're getting better? So obviously the sugars, but as the blood sugars started coming down and you reach the 250, then you kind of keep them at 250 until you fix the acidosis, the CO2, you close the gap, the anion gap, and the pH becomes closer to normal, 7.3. Those are the three main things you are going to be checking for when you treat patients with DKA and you're actively managing these patients. Some people say you keep checking the ketones and the ketones until they go away, and obviously you can do this in the urine. You don't necessarily need to check it on blood, but you can do it on blood as well. Now we have in our ER what we usually do is qualitative, either ketones or not, are there large, medium, small amounts of ketones. But some people have quantitative ketones and they can see various levels and more data of how they're getting better. One of the things I read is very important here is that diabetics should really not drink any carbohydrates. I mean sodas and juices and things like that. That any water mostly and things that don't contain sugar in them to keep their blood sugars under control. They also recommend, as a diet recommendation, that you don't need anything that goes on 4 legs, or at least diminish the amount. That means that you can of course eat fish because they don't walk on 4 legs, and snakes. Yeah. What else? Ooh, this is a kind of like a quick tidbit. Even 10 pounds, obviously people who are obese are more likely to be diabetic, especially type 2 diabetes. And even 10 pounds of gut can make you pre-diabetes. So a loss of even 10 pounds can make a great deal of good in preventing diabetic complications and things like that. If a patient presents in DKA or any kind of hyperglycemic state, make sure you consider the triggering factor. Was it just dehydration or was it infection? Make sure you listen to the lungs. You look at their urine for infection, but also, are they having a heart attack? Are they having a stroke? Are they using drugs? Anything that could have triggered them to go into diabetic ketoacidosis. Now we're ready to go. We talked a lot about the tidbits of DKA, diabetic ketoacidosis, and some high yield points in terms of treatment. Now we're going to talk about HHS, which is hyperglycemic, hyperosmolar state. And this is when the people have a very high blood sugars, but they're not ketotic. Their ketones are negative, they don't have an ion gap. And these patients are usually type 2 diabetics, and they go very high, as much as, like I said, I had patients that show with the thousands. The first patient showed up with the very characteristic marker of HHS, which is altered mental status. She's confused, she couldn't give us the right story, and she had a 1200 blood sugar. So this patient needed mostly fluids, and then of course insulin drip eventually. We did treat with insulin, but again, same caution, you need to know the potassium, to know their acid-base status and things like that. So usually with hyperglycemic, hyperosmolar state, the sugars are usually above 600, their CO2 is above 18, and the serum osmol is more than 320. And their ketones are negative, they are not acidotic. When you do give insulin to this patient, it is half the rate than you would use for DKA. So remember, in HHS, the insulin drip is half the rate of that which you give in DKA. These patients are altered, and sometimes they will need airway management. You don't want them to aspirate, they're confused, there might be thrushing, so you decide to intubate. If you decide to intubate either DKA or hyperosmolar state, then you have to make sure you match the pre-intubation respiratory rate. Remember, these patients were having Kussmaul breathing. They're breathing deep and fast. They're doing that to blow off their CO2. So if you don't intubate them quickly, and they start retaining more CO2 because you paralyze them to intubate them, and then by the time you put the tube, it's been a minute. Sure, their oxygenation might be okay, but their CO2 precipitated, they go into even worse acidosis. All of a sudden you have a patient that is coding and doing bad. So make sure you have your best person on hand in terms of intubation, and you do the intubation very quickly. And once you intubate him and paralyze him and put the machine on, make sure you match the pre-intubation respiratory rate of the patient. That means you actually put the ventilator at 40, 45 per minute if needed, so that their pH does not plummet after the intubation, or else you're going to have a peri-intubation code. No bueno, no bueno. And here's another tidbit. This is mostly for the nurses. is that when you do insulin drips, you need to prime the line. That means that once you prepare the insulin drip, it's in the back, you actually discard the first 20 cc's of fluid through the tubing. See, insulin actually binds to the tubing, so the first amount of fluids that you give that patient is not going to have any insulin. So by priming the line, then the insulin has already bound, so the new fluid coming down the line is going to have the appropriate amount of insulin. And that's it. Those are my tidbits and my learning points on diabetic emergencies. Remember, two main ones, hypoglycemia and hyperglycemic states. The hyperglycemic states are subdivided in DKA and hyperglycemic hyperosmolar state, in which they are not acidotic. In DKA, they're acidotic, they have ketones, their pH is low. But if you have a patient with very high blood sugars and altered mental status, then you think about HHS. And again, the insulin drip dose is half that of that used in DKA. And don't give insulin on either case until you know the potassium. The potassium will drop precipitously when you start giving insulin. It will get drawn into the cells, and the patient then go profoundly hypokalemic, and that'll send them into cardiac arrest, and that's no bueno. So this is it for now. Again, my intended audience are definitely healthcare professionals, because there's a lot of details. You already have to know what diabetes is. These are all like tidbits and high yield data for those managing hyperglycemia and hypoglycemia. We talk about hypoglycemia, about the patients taking long-acting hypoglycemic agents by mouth. They need to be admitted and observed. We talked about if the hypoglycemia is refractory, you can eventually give octreotide, kind of reverse that effect. And remember that when you give tons and tons of fluids, you start with normal saline, then you switch the fluids, and then eventually once you get down to the 250 blood sugar range, you actually have to give sugar on the fluids and keep the sugar hyperglycemic while you still give insulin to manage their acidosis, close the gap, and get rid of ketones. Hey, I hope you learned a lot in this video. I certainly learned a lot making it. So let me know how you like this format, whether you want to see other subjects discussed in this format, and we'll see you in our next video. Bye-bye.